Thank you, everyone, for joining us today at our third Spotlight Series weekly webinar on consumer engagement. So the whole month of October, we're focusing on consumer engagement, how to do it. We've seen some examples in the past week of projects doing consumer engagement, and today we're going to be focusing on evaluation and looking at whether it's meaningful engagement, and what are some of the outcomes that we can see. My name is Agustina Gancia. I'm the Consumer Engagement Senior Project Officer at Health Translation SA. So I look at all of the consumer engagement work that we do, all of the trainings, the resources, and I manage our community register database. So please get in touch if you'd like to learn more. Before we start the webinar today, I would like to acknowledge the Ghana people as the traditional custodians of the Adelaide region. We recognize the Ghana people's cultural, spiritual, physical, and emotional connection with their land. We honor and pay our respects to Ghana elders, both past, present, and all generations of Ghana people now and into the future. So Spotlight Series, what is it? As part of HTSA's capacity building program, our vision is to increase the capacity of South Australian researchers, health services, anyone doing research, involved in research, to do better research translation. And so part of that is having a quarterly spotlight series on a specific topic of research translation. And this month, October, is Consumer Engagement Month. During this month, we have weekly webinars. We promote available training, online resources, and publications through our social media accounts on LinkedIn and Twitter. Today, we're going to be delving into the value of consumer engagement, the evaluation of it, and meaningful engagement. And before I delve into that, I just want to reiterate who HTSA is and our purpose. Like I said, we're really focused on working around research translation. Our vision and our purpose is to accelerate the translation of research findings into action and healthcare practice and policy. And we want to increase the whole of system research translation capacity of the state. The way that we work is that we engage all of the different stakeholders that are involved in research, from education and training, policy, health services, research, as well as the community and consumers. And we act as independent catalysts and brokers to mobilize collaborations that address major health system challenges. So we really act as the connectors, and we do that by connecting people together or by training, building capacity. And so research translation is a mindset. It doesn't just happen at the end of a project. It's really important to know from the get-go, what's the ultimate problem you're trying to address? Who's the next user? Who's the next person who's going to use my research findings? And it's important to think about it throughout the whole journey of your research, from the start all the way to the impact and its sustainability. And part of increasing and improving translation is engaging with consumers and community members. And that's why we're here this month talking about consumer engagement. Today, we have two esteemed speakers joining us today. So the first speaker that I will introduce to you is Associate Professor Audrey L'Espérance. She's coming to us from ENAP, which is the National University of Public Administration in Quebec. She's joining us from Montreal today. She was a strategic advisor at the Center of Excellence on Partnerships with Patients and the Public in Montreal. Her work focuses on practices and public policies related to medically assisted procreation, experiential knowledge, expertise, and the development of public health policies. Over the years, she's developed expertise in program evaluation, public policy analysis, and project management in various academic and public health settings. So I would like to hand over the microphone to Audrey, and I will stop sharing my slides so she can share hers.
Thank you, Agustina. Thank you for the invitation. I'm really happy and grateful to be with you today. I would just like to begin by acknowledging that I'm located on unceded indigenous lands. The Gangaga Nation is recognized as the custodians of the lands and waters on which I work today. Janjage is historically known as a gathering place for many First Nations, and I respect the continued connection with the past, the present, and future of our ongoing relationships with Indigenous peoples within the Montreal community. Montreal is in Canada, for those of you who didn't get that yet. And so I have a little bit of a time difference with you. As Agu was saying, I'm from your past. It's October 19 here in Montreal. So if my English is not as fluent as it is usually, it's just because of the hour. So excuse me. I'm right from the back. I'm just going to share my screen so you can see my slides. I'm really happy to talk to you about the evaluation of patient engagement, and that's how we actually speak about consumer engagement here in Canada. I'm going to give you a little bit of context on why we do use the patient engagement I'd say label more than consumer or people with lived experience engagement or any other form. But you'll see that it's whatever language we use, it's probably the same principles or very similar principles that you apply in Australia. One sector in Canada that was particularly affected by the call for patient engagement in Canada is actually the health research sector. A sector where the monopoly of researchers in the production of scientific knowledge is still fundamental. And as some of my colleagues have pointed out throughout the years, the principles of objectivity and distance between the researcher and the research object that is promoted by conventional research have the effect of devaluing the lay knowledge in favor of the so-called neutral, and I'm putting quotation marks here, position of the scientific knowledge. In this context, users or patients who are considered necessarily biased and subjectives are traditionally excluded from the research process. Well, in 2011, there was a really big shift in Canada with the launch of the Canadian Institute of Health Research, CIHR in jargon, their strategy for patient-oriented research, which aimed to, and I quote here, support a continuum of research that engages patients as partners, focuses on patient defined priorities, and improves outcomes for patients. This change in models was intended as a way to accelerate the transition from research to clinical practice, to minimize the despised statistic of the 17 years between the lab and the clinic. That was a statistic that was circulating a lot in early 2000. And in order to demonstrate this kind of effect, it was necessary to be able to evaluate research practices, and above all, to give patients in the public a place in the learning health system that is now currently advocated as the model of choice in the management of care and social services here in Canada. As you can imagine, since the release of the CIHR's patient engagement framework in 2014, so three years later, patient engagement in Canada has been blooming, as is interest in its evaluation. Researchers were looking at the impact of patient engagement for sure. Several authors see the knowledge gap between what we want to achieve by engaging patients in research and what we know we have achieved as having a negative effect on those who are skeptical by fueling their reluctance to engage, while also hindering the work of those who are convinced of the importance of patient engagement by limiting their ability to learn from and improve their practice over time. Importantly, the call for robust evaluation of engagement practices resonated with both those who approached engagement from a normative standpoint, seeing, patient engagement as having an intrinsic value, almost a demarcative impediment, and also from an instrumental perspective, viewing engagement as a means to an end. So we wanted to know, what patient engagement was doing, also what effect it had on the research process and the research results, and eventually, people interested in knowledge translations, particularly, were interested in understanding how it could accelerate that translation practices.
Audrey, sorry to interrupt you.
No,
I'm just
no
wondering
problem.
if your slides, because we can just see your title slide. We can't see the slideshow.
Okay, let me see.
Sorry.
No problem. Let me stop sharing. And here you go. So I might not see you though, but you will see the whole slides. So
that's great. We can see that.
That's
perfect.
Great. So that's just what to go back to what I said, is that the spore strategy was almost a drastic change in Canada, and that actually grew the practice of engagement but with that practice was this inability to really follow what was achieved by teams, and also increase that that call for a robust evaluation, because people were whether very reluctant to engage, and that was mostly the case in basic science, and also with the people that were convinced and engaging in their own work. They were looking for some ways to learn and continuously improve what they were doing. So that kind of was a real spring for us to start working on the evaluation. And the first project that we started was the evaluation toolkit, which was actually a very simple project, a one-year project. Systematic review of evaluation tools to assess patient public engagement in research and health system decision making. That was published in 2018, and there's with a team at the Center of Excellence. But as we never do anything simply, we actually created this whole online platform for any potential users. So basically, you can get to the platform and have access to all of the 27 evaluation tools that we found through that systematic review, and actually get lists of evaluation tools and filter them to navigate and find the best available tool for your own context, from healthcare to health research, from more of an organizational standpoint to a more project or participant standpoint. So we categorized the whole list of evaluation tools, but we also described them very thoroughly by giving users their names, their reference, have a link to the tool so they can download the tool if it's available, but also give potential users an assessment of the tool. Because that project was funded by SPORE entities. The SPORE entities are methodological platforms that are spread across Canada and supporting patient engagement across Canada. They wanted something that would actually help people choose whether through that list and find the best one for their purposes, not necessarily having the same type of criteria in mind. Some projects wanted to value usability, the usability of the tool more than the scientific rigor, but some others wanted the scientific rigor to actually be the the most important criteria. So we actually identified the 4 criteria with our the sport community, and that community helped us get to a grid that I can actually show you in detail later. That was an interesting project, and it's a really useful platform, and the evaluation toolkit was the first step, but we got to a point where we knew that we were already, we were having this really fancy toolkit, but without really knowing what we wanted to build. So that question of what is good or meaningful patient engagement was still pending, and what we needed, it was a blueprint. And so we started in 2019 the Relate Age project, which is has as an objective to develop a national adaptable framework for the evaluation of patient and public engagement and research. We wanted to build consensus within the Canadian community on core evaluation criteria, process indicators, and impact indicators. So by the way, what we will see today is mostly transferable, but you might see a little bit of a few, dimensions or indicators that you wouldn't want to see in your own context. That was completely, that's completely possible. We knew that the transferability of the model was less important than the transferability of our method to get to the model. So and so that's why we published the protocol, because we thought that other teams that would want to have, an evaluation framework would probably want to do the process or know about the process more than about our results, which is very Canadian in nature. The research team is amazing, and I really like to show their face. So we're a very big bunch of us, and Antoine Boivin and I are working, and we are grateful to work with 2 patient partners that have tremendous experience in research. So, and we have tons of collaborators coast to coast from Canada. So Canada is a huge country with a lot of partners, and that work has been great because of them. So we actually had 3 phases to build that research project, to that evaluation framework. The first phase was consensus building exercise, where we identified the broad dimensions to build the logic model. And then we did a literature review to build a questionnaire with lists of indicators that were present in the literature for each of the dimensions. So you'll see it was a very extensive questionnaire that went through 2 rounds of Delphi. And the third phase was experts working groups on equity, where actually expert working groups were looking at the adaptation and implementation of the model in specific seldom heard groups like youth, caregivers, people affected by social inequalities, immigrants, and Indigenous communities. So we knew that in these particular communities, we might have to, extend or go a little further in the adaptation of the model. So I'm going to go straight to the model, and if you have questions on, the method and how we got to the results, just go ahead and please ask any questions you have. But this is the model, and it will be also a web-based platform where actually you'll be able to navigate and click on any of the elements you see on this graphic to have list of indicators for each of the dimensions. So what we have learned is that people wanted to have like these 3 moments of engagement. The first moment being when you enter into the engagement pathway, where you have to define what types of perspectives you want to bring in, how you co-build the roles and responsibilities of partners, how you can actually lean on guidelines and policies that exist, your level of readiness as partners, and how you co-build that project. And what will be the forms of appreciation, compensation, reimbursement, onto like other types of appreciation that are less financial, but can be more qualitative in nature. And then you enter into that loop of engagement. And one thing that the participants to our project told us, and just so you know, there were almost 140. We had on 147 people involved at all stage of this project. Sometimes consulted, sometimes participants, and sometimes partnering with us during the project. And one thing that they really wanted to tell us was that the patient engagement journey is not linear. So the graphic designer created that loop where you actually, enter into that welcoming environment, but refining the engagement is just, navigating within this loop, where you need to, recognize, include, communicate, support, and improve your partnership all the way through. And that will also get us to transformation. Another very important message that people told us was that, patient partners are not getting involved in research because they want to, just be partners. They want to transform healthcare. They want to change the way we do research. And that was an interesting thing for us because, we asked them, further questions about, what type of transformation are you talking about? And we built that mountain you see in the design. And the first step is capacity building, and it's changing actually the partners and their abilities individually to engage better. Then transforming their practice. So sometimes like researchers are also clinicians or they are methodologists. They have other types of practices that they can change because they are engaging in their research. And then refining the research per se. So having a better research, a more ethical research, a more well-structured one, a more transparent research. And eventually changing the culture of research, which also was defined in more specific and tangible ways afterwards. Then transforming care and improving systems, which are optimal outcomes of patient engagement, and probably not necessarily feasible to evaluate on the shorter term. But most of our participants said, if you're not putting it in the framework, we won't ever be able to actually project ourselves into that future, that future we want to achieve or get to. And so, so that's the graphic design, but and those are the dimensions. But for each of the elements I just showed you, navigators will be able to click on each element and see detailed, and I'm going to give you detailed lists of indicators that came out of the Delphi process, where we identified, with stars, the core indicators, the ones every evaluation framework should have, and with the other little check, those that are nice to have. So if you're a little bit looking for something a little bit more comprehensive, you'll go a little deeper and add those little elements. And if you look at these lists, where we identified the indicators of what we want to measure or what we want to actually monitor, and not how we want to monitor it. So many of these indicators can be actually monitored qualitatively or quantitatively, and that will be of the choice of the users. And so just for the sake of time, just stop the presentation, but as you can see, I have like all kinds of details I can give you. Just want to keep it open for questions. And by the way, just a bit of information, the the framework will be available at the end of November in French and in English, all interactive online on the Center of Excellence website as well, just right by the toolkit. So if you go navigate the toolkit in the next days, you can go back in November and you'll see the framework as well.
Thanks, Audrey. That was fascinating and really informative, and that was such a great graphic. And I love that you can click on each of the terms and then get the list of indicators. That's going to be so helpful for researchers. What an amazing work that you've done over the years. I know it's been going on for a little while.
Yeah, and thank you for that. It's like the interest for us was also to keep people and not overwhelm them with all these lists of indicators and make them navigate like with levels of interest, because someone that will be planning for engagement can look at the framework to orient themselves, and others, if they really want to go into that deep dive into evaluation, can actually go into the list of indicators.
Yeah, no, that's excellent. And I'll make sure to share the toolkit as well as the framework when it's available through our networks. So if anyone's interested in getting access to it, just stay tuned on our socials, or even just go to their website. But I'll post it as a reminder. I see there's a couple of comments on the chat. Someone was referring to the Canterbury Tale Integrated Care the Kiwi Way. So it's a similar framework, it seems. And there's a graphic there available, which is great. Thank you, Kate, for sharing. Would anyone else have a comment or a question for Audrey about the framework, about the work that they've done in the past, or about even, you know, applying it to your own projects? If you have any questions about your own projects or comments. No, is there silence? Okay. Why don't we hop on to Sarah's presentation, and then we can regroup at the end for questions to both presenters. So before handing over the microphone to Sarah, I'd just like to formally introduce her. Sarah is an independent consultant. She's working in public health with a focus on building sustainable capacity for tackling social determinants of health inequities and gender inequality. She has over 20 years experience of working in health and or public health policy and program development in a range of diverse country and health policy contexts. She's the director of EquiAct, a co-investigator on the Shaping Health project, and an adjunct lecturer at the Centers for Primary Healthcare and Equity at the University of New South Wales. So I'll stop sharing and hand over to you, Sarah. Thank you again for coming.
Sorry, thank you, Augustina. I'm just going to share my screen with everybody. And thanks, Audrey, for that great presentation, which I think will segue nicely into what we're going to talk about now. So can everyone see my screen? Yes, because I can't see anyone with the screen on the presentation. So I just like
I'm sorry, Sarah, I can't see your screen.
You can't see it? Okay,
No.
just a sec. All right, let me get out of and show. I need to do the share
green
screen
button,
then.
share screen.
Yep, I thought I had. Sorry about that. Okay, guys. All right, so let's go share. And just perfect. And just before I do, just to say that I'm speaking to you today from the Bunurong lands of the Bunurong people of the southeastern Kulin Nation. And I wish to acknowledge them as traditional owners. And I'd also like to pay my respects to their elders, past and present, and Aboriginal elders of other communities who may be here today. So I'm just you're not seeing that as a presentation at the moment, are you?
No.
So I just need to make that a screen share and go from there.
Perfect.
So one of the things actually, and it was interesting with Audrey's presentation, I'm going to talk to you about why an implementer's resource on social participation in health, understandings of social participation in health just briefly, and give you an overview of the resource, its audience and how it's structured, and a quick example. And I had the privilege to also sit in last week on the presentations in the second webinar, which were really brilliant and inspiring, and in their own way reminded us of some of the history and some of this work. So why have an implementer's resource on social participation in health? So social participation and power in health is happening both in research and at community level on a range of different fronts around social determinants of health and through all levels of different health systems. But how do we know that these efforts are making a difference? And I think Audrey also touched on this. There's a lot of work from the early 2000s and end of last century where we were beginning to look at this. And what do we evaluate? And oftentimes there's a lot of questions over what we do evaluate, and maybe tensions about that, because evaluation findings might be seen as potentially to be misused if there hasn't been seen as progress. So we'll discuss some of that. And then how do we assess, review, use and communicate evidence that shows the outcomes from efforts to strengthen social participation in health? And that's beyond things like, you know, how many people are represented on a committee and where do they, you know, what's their background? It's a range of other issues. So social participation in health is a means to better health and an end in itself. It's also known as community engagement in health. There are many different ways of talking about it, but it draws on shared values and goals, and it aims to develop literacy practices and capabilities at all levels of the system. And I think sometimes engagement around research may be more challenging than some of the community projects to some because of the really different and formalized structures, but it still is happening and in a really powerful way. And we saw some important examples of that last week. It brings community needs, priorities and capacities into planning and health decision making, from research to services, as we're saying. And if used properly, it makes the health system accountable to communities. And if I can just pause there about making health systems accountable to communities. One of our presenters last week reminded us of this ladder of participation, or what the International Association for Public Participation calls the continuum of participation. And what often happens is participation, particularly patient participation, we see it from the World Health Organization and other health systems, can be misused in terms of what is said is being done on that spectrum to what actually the level of participation is. So, you know, many of you will be familiar with the idea of we go from informing to consultation through to collaboration and co-design. And often at a health system level, there'll be quite highfalutin rhetoric about co-design and collaboration, whereas what's really being talked about is, say, consultation or better engagement, and we're not at collaboration yet. And so that's both important when evaluating the participation to be clear on what the goal actually was, but also in terms of not over consulting and disappointing people. And so I think that's where evaluation of social participation can also help, by clarifying the goal and the intent of the participation from the different stakeholders so that it's evaluated correctly and within the right context. So where does shaping health and making change visible come from? And you'll be able to see the link and to the implementers resource after this and access through the slides. Shaping health was about developing a global community of practice. We receive support from the Robert Wood Johnson Foundation through their International Charities of America Foundation, which is like their international arm, and the Training and Research Support Centre, who I was contracted to work with led by Renee Lowenson and the team of us, with the Shaping Health project, was really to document a range of experiences around social participation in health. And so I did an annotated bibliography. We had several detailed case studies from different countries, as well as short case studies. And a website was created, the Shaping Health website. We had also the Robert Wood Johnson Foundation. What we did was we connected it back into 5 sites within the United States of America in terms of learning sites, and the leads from those sites participated in 2 meetings with us, and also we wrote some practice briefs with them about their experiences of social participation in health. And then choosing case studies. The case studies were chosen in consultation with the 5 sites in terms of where they felt the most learnings would be. And so at the end of that exercise, which took place over 2016 to the end of 2018, we actually did all that work. And then what became evident was that social participation in health, as Audrey has been talking about, is not necessarily very well measured or documented or evaluated. There's a lot of investment in documentation of process indicators, but very little around performance evaluation and longer term outcomes and impacts beyond that. And so then this led to the idea, as I've said here, a concern about extractive evaluation in social participation in health. And so it initiated the Making Change Visible team, of which I am a member with Renee and several others, to create a resource for community engaged evaluation of social participation in health. And interestingly enough, I see that Audrey's project began after we had started, to some extent, the annotated bibliography, and then when we were starting to do the creation of the resource. So these initiatives have been running in parallel. The actual implementers resource was launched towards the end of last year and has been available for a while. And we started piloting, and I had the good fortune for Augustina and the Consumer and Community Engagement group with Health Translation South Australia were a pilot site for us to do 2 1.5-hour sessions to discuss the resource. So just tell me, Augustina, if I'm going over time. I'm trying to keep an eye. So who is the resource for? In different countries and globally, for all those implementing social participation in health interventions. So that can be local practitioners through to program directors and local managers. And for those working with implementers in terms of health systems managers, academia, researchers, government and non-profit agencies. And for funders supporting social participation in health programs. So this is a short overview of what the resource looks like. It's divided into 5 parts, as you'll see there, and you can, in the electronic version, very easily, you click on the tabulated part and it will take you straight to that relevant part. So it's hyperlinked that way. So it's about using a theory of change and then establishing a baseline. So it's framed around basically the 3 kind of main frames for evaluation. So establishing a baseline to plan and track change, evaluating performance and enabling course corrections, and then assessing and communicating outcomes and impacts. And those last 2 types of evaluation are often not very well done or followed up from in work around social participation in health. One of the other messages about the resource is that that we've had to increasingly communicate is that it's not a resource for how to do social participation in health. There are many resources like that, but really about how to do it with regard to evaluating social participation, and we drew on many extensive evaluation sites. And I did come across the Canadian work that Audrey's talking about when we were putting the evaluation resource together. It has links to resources, tools, real examples, and definitions. And I think it's only going to grow in terms of people coming out and talking about these examples. I think one of the things that we'll also probably all be reflecting on is the experience of publication time lag. In terms of some of the examples of evaluating social participation in health may have been around when we were starting to do this work, but not necessarily well documented because people are usually busy doing it. So as I said, the key areas are covered in all 3 stages of evaluation. So parts 2, 3, and 4 to some extent look similar, but they're similar in terms of what evidence to collect at this level of evaluation. Ideas about methods to choose from with links for more details, a bit building on what Audrey has shown you with the Canadian work, which is, examples of types of indicators at each stage and in relation to different types of projects. And so it's guiding you through a stakeholder analysis. It has a range of worksheets that are attached to each section, which are also meant to help you in the practical application and in terms of teams working through the different worksheets. And it helps you about how do you organize, communicate, and use the findings. So not just doing an evaluation that sits on a shelf or is used by the funder to either stop funding the program or to continue funding it. So there's discussion about how to communicate that. And then how to manage challenges all along the way in terms of either within the team about concerns or in the community about concerns about evaluating efforts. Because whilst all the programs are often well-intentioned, we all often get apprehensive about evaluating our program and how things might be misused. And likewise from up to the donors and to other funders. So it provides methods, advice to guide social participation in health teams through all stages of an evaluation. And like I said, worksheets to guide teams. And advice, as I said, on how to address challenges. So again, in an accessible and interactive way. So here's an example of the color coding throughout the resource about, your yellow text boxes, the practical how-to. The team, we did a lot of work drawing. We all did research different areas or different parts of the globe in terms of examples. We also all did different key informant interviews with different people who were doing practical examples. The icon also shows links to more comprehensive guidance. We have real world examples. And as you'll see, we actually have one example that's used throughout the document that draws on one of our US sites from Ruth Dodds, because that's one of the 5 US sites that's really followed this work through in terms of application at a local level and evaluating it. So there's a range of different areas, and part 5 includes a glossary and a summary table of all the tools, which you'll see there. So there's also lots of tables throughout and different tools, again, providing different potential indicators and questions to think about. So this is just a quick overview because I think I'm running close to time. We want to leave some time to have any questions or discussion. So part 1 is just having this discussion about embedding evaluation as a strategic process, and the diagram that Audrey showed us, which I really liked, that it shows that kind of negotiated conversation about also what the participants, the community participants, or consumer and community engagement people want to get out of different things. So having that conversation, including about using baseline evidence to plan, performance evaluation to assess if work is progressing as planned, and assessing outcomes, and really having those discussions from the beginning. And then in part 2, we really talk about establishing a baseline, including this idea about a theory of change, and where it really becomes apparent that it's important to have the different stakeholders around the table, because oftentimes we think we know what we're doing and why we're doing it, but when we all get together, we might all explain it a little bit differently. And that's key to, developing a sound baseline in order to be able to measure before and after. And as many of you would know, that often gets overlooked or done as an afterthought. So there you'll see that it follows the same kind of idea as the other sections will follow. Establishing the baseline, what evidence to include, what potential methods, how do you organise, communicate and use the findings, and how do you plan for challenges. And there are linkages back and forth between the sections rather than always repeating the same sort of information. So part 2 is about progress or performance evaluation. So for strategic review and what we call course correction, do we need to tweak the program at this stage? And the Aboriginal kidney program that we heard from last week talked about that some of their health journey learning and mapping has enabled them to adapt the program as they've gone forth. And so the importance of reviewing the monitoring data so that we can see how we're going and where we can improve, and also where we can stop things that might be going off course and doing harm when no harm is initially intended. And then finally, outcomes and impacts after an intervention. So as you'll see there, disabled people know we never had any of them coming into the clinic, and there's a huge stairwell there. So there's a lot of really powerful work and evaluation resources that we were able to draw from, and a strong history in Australia around social participation in health, but less so around evaluating social participation in health efforts, more around community arts interventions and/or environmental interventions. There seems to be a longer follow through on evaluating public participation in those kind of fields. So just to give you a brief overview, so as I said, the resource follows through with an Amish and Mennonite evaluation story, which is about the introduction of community health workers in Ohio, where there are the world's largest Amish and Mennonite communities, and using the community health workers in terms of breast cancer and addressing barriers to breast cancer screening for women where there was a leading cause of death. And so if we look at the Amish and Mennonite evaluation story in terms of performance evaluation of the community health workers, they undertook regular follow-up verbal surveys and key informant interviews. But what they recognised was that having surveys with the community health workers themselves was critical, because the Amish and Mennonite women themselves did not feel comfortable telling researchers what was wrong with the program. They were not comfortable to do that. So that, was identified early on as a key source of information, even though the community health workers themselves are drawn from those communities. Discussing the results of the performance assessment activities among the team members, with the advisory group members and with program participants to enable that course correction. And then reviewing some of these, what is seen as less tangible aspects about how community ownership of the program, power relationships and partnerships changed over time, what was working or not working. I mean, one of the powerful things about the example we heard about the Aboriginal kidney management program last week was this idea about people receiving dialysis and kidney treatment were also co-investigators on the research around the new approach, as well as recipients, as well as involved in the advisory group. And so understanding how that's working. And then team self-assessment survey, how was it? Surveying and evaluating, and using retreats to talk about and deal with concerns that may become challenges in communicating the findings. So just some ideas that came out for us, because most of us who are involved in the team come from equity and social determinants backgrounds. And it's easy how often this idea can get overlooked. And so most of you will be possibly familiar with this idea that the performance measures should be smart, but they also need to be inclusive and consider equity. So the idea that we want performance measures that are SMARTY, specific, measurable, achievable, relevant, time-bound, and capture inclusion and equity, and SPICED, which came out of a piece of work in the African region. So subjective, participatory, interpreted, communicable, cross-checked and comparable, empowering and disaggregated. So we can't assume, as I was saying, that the underlying features of social participation in health have been addressed. We always need to keep an eye on representativeness. And I think, again, Audrey touched on that. So, you know, did we involve in the intervention the right communities, and how are we measuring that? Are we measuring equity? Are we using data, and how is it disaggregated? And are we looking at gender and disability? And are we looking at processes and power dynamics that lead to the isms, the ableism, the racism, the impact of colonialism, those sorts of issues? So how are we doing that? And how can we then scope the evaluation with an eye to keeping it not becoming overwhelming, knowing that more often than not, evaluation is not well funded? So we talk in the resource about involving communities in reporting change. And so that's one example about the Smart and Deadly Koori program. So just touching on that. And I just want to touch on last week's presenters, the Aboriginal Kidney Care Together, because it was really powerful. So hopefully some of you who weren't present last week can go and listen to the presentations from webinar 2, but also to see the Aboriginal Kidney Care Together Improving Outcomes Now project, which is part of this wider health journey mapping project by Adelaide University, where Aboriginal people are reporting the change at conferences as part of the research team. And this information in terms of communicating findings is feeding into the ANZ dialysis and transplant registry. And the Croaky articles are really interesting. So that is just a wrap up. At the end, we have the worksheets, the resources, and the next steps on the implementers resource. And where to next? I'd encourage you to visit the Shaping Health webpage on Making Change Visible for both the resource as well as the case studies, and share your thoughts. And hold on, I obviously need to click on all of these ones and give feedback if you're going to be using it. And then that's just a wrap up about who developed it, and really acknowledging both the colleagues in the teams and our peer reviewers and other contributors, and HTSA for being one of the ones to start piloting with us the ideas. So I'm going to stop sharing now, just to thank everybody, and my contact details are there. So thanks. Sorry, I've gone over time.
That's fine. Thank you. We still have a few minutes before the end of the webinar. So I'd like to invite any questions or comments from the room. If I'll maybe start with a comment. What I really liked about both frameworks that were presented today is that, you know, oftentimes people think about evaluation as something they do just like at the end of the project, like, all right, I should reevaluate what I've just done. But what's been highlighted in these both resources is that this is actually something that needs to be thought of right at the start. And by actually structuring your project around like what are the things that you want to measure later down the track, then it actually ensures that your project is actually successful at the end of the day. And you know, it helps you remain accountable and down the track, and actually adjust where you need to adjust if there are any adjustments to be made. Especially, you know, involving community members and consumers and patient partners. So that's something that I really think is important to highlight when we talk about evaluation. And those two frameworks are really great at demonstrating that. Any other comments from the room? I also liked a comment that was made by, I think it was Sarah, around publication lag and like lack of time perceived by researchers to do evaluation. Are there any tips that either of you would give to researchers or research teams that come up to you with that challenge or that question?
They already evaluate. They just don't know it yet. And they sometimes want to do it so thoroughly and so, you know, with the same amount of energy and the same amount of rigor than any of the other work, that they get stuck in process actually. But when you look at it, they already have tons of information that they gather just in the course of their work and their engagement, and I think that's the key. It's to make them see all the information, all the things that they already do, and actually create some moments within the process for them to stop and have, you know, a more of a reflective moment on their practice. That's the hardest part. That's, you know, but weirdly, like the researchers I work with, they think that the hardest part is to keep track, which is actually the easiest part. The hardest part is to reflect and have the time to reflect, step back from the project and reflect only on the engagement piece once in a while, so you can actually go back. And that's the refining that happens in that loop. That actually is, I think, the hardest part for the researchers. And also for some patient partners also, because they are sometimes really, really, they wanted to go fast and get to that transformation piece as soon as possible. And that can be kind of a weird equilibrium to get to.
Absolutely. Sarah, you raised your hand.
Yeah, I mean, I think one of the things that I noticed, and I kind of pointed to it in terms of being clear about what the objective of your participation is, and then scoping it. So one of the things, it's easy, and I think you've both pointed to this, to become overwhelmed by how many indicators you might measure. And actually the same thing when we're trying to present it. But to say that, okay, we need to scope realistically for how the project's going to go. And so if you want to be able to follow the evaluation through, then let's scope it so that it's workable, and that if we can bring in more measures as we go to see how we're going, great. But it's really trying to get people to agree on what and how they're going to measure, scope it, and then keep a track on that, have some kind of process. I find that we're often really bad at scoping what we want to do. We want to do more, and then when we come, as Audrey's saying, back to look at it, there's a lot. I think the powerful thing that struck me was, you know, like I said, I contacted Janet after their presentation last week and wanted to know if I could, say, use their slides or if there was anything. And they sent me the Croaky articles. And so I think it's like that, getting researchers more connected with putting some of that stuff out early on, and maybe changing some of the ways that we, you know, oftentimes in traditional research structures, we can't publish because of either like a funder thing, or we're going to be doing a publication. And if you've already put it out there, you know, there's a thing about it's already been in the public domain. But actually, we want it on the ground with the people who are being affected by it as much as anything, because if the funders are starting to take what people at community level are saying and consumer reps are saying powerfully, then they need to be on board and saying that, yes, it is working for them and this is what works, and in a way that works for them to communicate it, and to communicate it in a way that policymakers or funders listen to. So I think maybe, as Audrey's saying, making better use of it as we go along, but maybe also who's involved in sharing that if we're continually putting it in the researcher's hands to share it in a formal evaluation way. So there are questions also about when we evaluate it, is our evaluation process participatory as well?
Absolutely.
You know?
I see that we've reached 1 p.m. and I'd love to continue chatting to both of you about evaluation. But we need to close this up for this session. I encourage everyone to go back to our website and see all the previous recordings and to join us next week for our last of our 4 series. And we'll be looking at embedding consumer engagement in grant applications. And we'll be actually speaking with a panel of 4 reviewers, 2 of which are consumer reviewers, one for the NHMRC, the other one for the MRFF. And they'll be telling us tips and tricks, things they want to look out in grant applications, things that you should do. So it should be a great panel. Join us next week for our last Spotlight Series webinar of the month. And then our next series will be next year in 2023. If you have any questions or have any comments relating to today's webinar, please contact us at our HTSA email.